Dear Chairman, dear colleagues, I first would like to thank the French Intensive Care Society to have invited me, and I will now talk to you about septic shock-induced coagulopathy, which includes disseminated intravascular coagulation, which I will now call DIC. DIC is a very complex issue for the physician. First, because we do not really know what DIC is, how to define it, how to prevent and how to treat DIC. The only thing we are sure is that once our patient develops DIC, his outcome is poor. Sepsis and septic shock are major healthcare problems affecting millions of people each year around the world and killing as many as nearly 1 out of 3. Septic shock is due to an inadequate host response to an infection leading to multiple organ failure and death. But septic shock may also lead to dysregulated coagulation activation and defective fibrinolysis, leading to DIC in 1/3 of our patients. Patients with symptomatic DIC may develop 2 types of clinical signs, including bleeding complication and microthrombosis. Microthrombosis are usually visible on fingertips and toes like here, but are also present on microcirculation from organs, leading to organ hypoperfusion, organ dysfunction, and subsequent death. DIC was indeed recently shown to be significantly associated with mortality. And for the same underlying disease, DIC is responsible for an increase from 40% of the mortality. What was interesting is in this study is that the higher DIC score was on the right, the higher was also mortality. In this context of disseminated microthrombosis, one of the therapeutic options might be limiting excessive coagulation activation. Yet, it is not recommended for the moment, and even if the physician wanted to anticoagulate his patient, which anticoagulant to use is still debated. Many anticoagulants have already been tested, blocking the coagulation pathway at different levels. A randomized control trial with TFPI versus placebo in sepsis and septic shock patients showed no improvement of survival in septic shock patients, but an increased risk of mortality, of bleeding complications. And although antithrombin plasma activity is decreased in sepsis and correlated with DIC and death, supplementation with high doses of antithrombin did not improve mortality either, but significantly increased bleeding complication. And it was the same thing with activated protein C, which was recommended for 10 years by the surviving sepsis campaign and finally withdrawn from the market for futility. So far, the surviving sepsis campaign thus recommend against the use of antithrombin for the treatment of sepsis and septic shock, but made no recommendation regarding the use of thrombomodulin and heparin. And one of the reasons why is that there is a randomized control trial with thrombomodulin, which is still ongoing and should finish soon. So far, the recent clinical trials are disappointing and with either inconclusive or negative results. And part of these negative results are due to our inability to detect properly DIC and to determine its clinical stage, which has led to inappropriate anticoagulant treatment allocation in some of our septic patients. So we have to find a way to diagnose DIC and to stratify our patients. We have many available scores to diagnose DIC, but these scores have been established in different clinical settings, and the matter is now to find the score that is the most suitable for my patient. The ISTH score has been established with global hemostasis parameters, including platelets, TP, fibrinogen, and D-dimers, and has been validated now in different clinical settings. But the only one that has been validated in ICU is the HELMS score. And the HELMS score is probably the most appropriate for septic shock patients because it includes the kinetics of platelet decrease, it includes higher D-dimers value, and it does not take into account the fibrinogen, which is always elevated in septic shock patients. And to adapt to the last definition of sepsis and septic shock, the HELMS score has been redefined, replacing SIRS parameters with antithrombin. In spite of all these available scores, we still fail to detect early DIC stages. And these stages are sometimes called pre-DIC patient. A pre-DIC patient is a patient that will be hospitalized in ICU at day 1 for a septic shock, for example, and who will have no clinical signs of DIC, who will have a negative score of DIC, and who will, by day 2, develop a patent DIC. And the matter with these patients is that they have the same mortality rate than DIC patients. So we have to find new diagnosis tests to identify these patients early and even and possibly to treat them before they develop patent DIC. And in Strasbourg team with Professor Mesiani, we have now worked for nearly 10 years on vascular cell dysfunction in septic shock, and we have made the hypothesis that microparticles may be markers of this vascular cell dysfunction in septic shock-induced DIC. Microparticles are small vesicles that are emitted by all vascular activated cells. In a multicenter clinical trial, we have thus shown in 92 septic shock patients with 40 DIC that we have a significant increase of endothelial microparticles from day 1 to day 7, which means that during DIC we have an endothelial activation. It was not really surprising. But what was far more surprising is that we also had a significant increase of leukocyte microparticles, meaning that during DIC we have both an endothelial and a leukocyte activation. We have confirmed these results in a new cohort of 265 patients, including 93 DIC. And we have shown that among leukocytes, it was neutrophils that were significantly activated. Neutrophils are key cells of innate immunity. They take part to host defense against pathogen through degranulation, through microparticle release, through diapedesis at site of infection, but also through netosis. And netosis will take part to pathogen trapping and destruction, but netosis will also take part to coagulation activation and to disseminated microthrombosis leading to organ failure. So neutrophils thus stand at the interface between immunity and hemostasis, which is called immunothrombosis. Immunothrombosis refers to an innate immune process that will be responsible for vascular cell activation, including leukocyte, platelet, and endothelial activation. These activated cells will lead to microparticle release, which will also lead to coagulation activation. Immunothrombosis is thus a normal process during infection and will help host to defense against a pathogen. But during DIC, this process may be deregulated. Indeed, during septic shock, we have an excessive activation of leukocytes leading to oxidative stress, leading to excessive platelet and endothelial activation, to excessive netosis process, and to excessive coagulation activation with defective fibrinolysis. And this is what leads to DIC. So neutrophils thus play a really key role in septic shock-induced DIC. What was interesting is that some of our septic shock patients displayed abnormal neutrophils with vesicles under the membrane, with a round nucleus, with a cytoplasma that has degranulated, and with depacted chromatin. And when we use these abnormalities, these morphological abnormalities in a cytological score, we have shown that only DIC patients displayed these abnormal neutrophils. And we wondered whether these abnormal neutrophils were related to NETosis. So we have quantified indirect markers of NETosis in plasma, and we have indeed shown that only DIC patients had increased marker of NETosis in their plasma, which were nucleosomes, which are a specific of NETosis, and DNA MPO complexes. So if I had to summarize recent advances in DIC pathophysiology, I would remember you that DIC results from an early leukocyte and endothelial activation. I would add that microparticles are early markers of this vascular cell activation during DIC. We have also shown that neutrophils play a key role in DIC pathophysiology through NETosis process. And finally, DIC results from a deregulation from immunothrombosis process. From the clinical viewpoint, during sepsis, you have a coagulation activation, which can be called adaptive hemostasis. When this coagulation activation becomes deregulated, then it leads to DIC with a first stage of thrombotic DIC. And finally, the bleeding stage of DIC when platelets and coagulation factors are dramatically decreased. From this graph, we can easily understand that we should not treat all our patients the same way. At the adaptive phase of hemostasis, we should probably respect the activation of coagulation. At the thrombotic phase of DIC, we should prevent thrombotic complications by anticoagulating our patients. And finally, at the bleeding stage of DIC, we should not anticoagulate our patients. So far, more than half of our septic shock patients with DIC will die. So we have to diagnose DIC with available scores, but we also have to find a way to establish a stage of coagulation activation of our patients, and maybe by using cell-based hemostasis, which has shown that we have an early endothelial and leukocyte activation. And finally, we have to find a way to better stratify our patients eligible for treatment. Thank you.